Hi, very good morning. I am Dr. Janak Patel, MD, General Physician. In continuity with the previous lectures, I'll be taking today one of the cranial nerves, that is glossopharyngeal nerve, ninth cranial nerve, or we call glossopharyngeal nerve. All my video lectures are mainly for educative purpose. This is a important lecture very frequently for your oral exams, also can be asked in your theory, and you might come across in your everyday practice. So it will be helpful to you also in your day-to-day practice. So glossopharyngeal nerve or a ninth cranial nerve, by and large we combine together glossopharyngeal and we call 10th cranial nerve. We usually examine together, but I'll be talking little bit separately of both, but some of the examination may be common for ninth as well as 10th cranial nerve. Now this glossopharyngeal nerve arises from medulla. It comes out anteriorly and it will come out through jugular foramen along with 10th and 11th cranial nerve. So these are the three cranial nerves which will be coming out, that is 9th, 10th and 11th. 9, 10 and 11 plus internal jugular vein. So this will be the three cranial nerve which will be coming out through jugular foramen, and there will be lot of interconnection between 9th and 10th, and ninth number will be supplying some of the structure which we'll be discussing now. One of the structure which it supplies is posterior one-third of the tongue, and that is a taste sensation. Sensory and taste sensation to posterior one-third of the tongue, and that is by ninth cranial nerve, glossopharyngeal, and motor supply is by hypoglossal. Anterior two-third of the tongue by seventh cranial nerve, chorda tympani branch of seventh cranial nerve, but it combines with lingual branch of mandibular division of trigeminal nerve. So we'll be discussing further as we go through. So now glossopharyngeal nerve will be sensory, spatial visceral sensory, motor, parasympathetic and spatial sensation, that is we call taste sensation. So sensory supply is to the oropharynx, posterior one-third of the tongue, tonsillar area and also the middle ear. So it is supplying a sensory to all these structures, of which we take the advantage of oropharynx and posterior one-third of the tongue, and this we take in gag reflex, or we call palatal reflex, a part of gag reflex. While there is a visceral sensory to carotid body and carotid sinus, which takes part in reflexes, motor supply to stylopharyngeus, which helps in elevation of the pharyngeal part, and it supplies parasympathetic fiber to parotid gland, which takes part in salivation, and it supplies taste sensation to posterior one-third of the tongue as well as little part of oropharynx, which takes part in sour and bitter taste. These are the different supply. So there is a sensory supply to middle ear, tonsillar area, pharynx and tongue, and baroreceptors and chemoreceptor to carotid body and carotid sinus, and taste sensation to posterior one third of the tongue, as well as to the parotid gland. This will be the entire supply of glossopharyngeal. Again I am repeating. Sensory supply to middle ear, tonsillar area, pharynx, tongue. This is sensory supply. And we take the advantage of sensory supply to the pharynx in the form of gag reflex. When you touch the pharynx, you get a gag reflex, a part of a gag reflex. And also, you will have an elevation of the soft palate, that is stylopharyngeus muscle. This is only one muscle which it supplies, stylopharyngeus muscle. So it takes part in elevation of soft palate. So this will be one supply of glossopharyngeal. While it supplies to the parotid gland, and parotid gland will be responsible for salivary secretion. Usually we don't taste this. There will be a special taste supply when you want to identify the damage to parasympathetic supply to the parotid gland. And you can taste the posterior one third of the tongue by different taste, that is bitter and sour taste. Bitter taste and sour taste. So that will be that particular area. So parotid gland, middle ear. It also has got little supply to the dura mater, then stylopharyngeus muscle, tonsillar area, pharynx, soft palate. So we do taste for palatal reflex, or we call gag reflex. So this will be all the different supply. This is the best diagram which tells you everything. So motor supply to stylopharyngeus, sensory supply to middle ear, tonsillar area, pharynx, tongue, even soft palate, then visceral sensory to taste sensation to posterior one third of the tongue, and baroreceptor and chemoreceptor to carotid body and carotid sinus, and parasympathetic supply to parotid gland. So it is a mix now. Sensory, posterior one third of the tongue, pharynx, tongue, sensory supply. Motor supply to stylopharyngeus muscle, and secretomotor, or we call parasympathetic fiber, to parotid gland. So function is sensation and special sensation, that is taste sensation to posterior one third of the tongue, as well as the pharyngeal part, and carotid sinus and carotid body, chemoreceptor and baroreceptors. Secretomotor fiber to parotid gland, and motor fiber to stylopharyngeus muscles, and which takes part in swallowing. Same somatic sensory to skin in middle ear, tonsillar area, pharynx and tongue. Visceral sensory, baroreceptor and chemoreceptor from carotid body, aortic sinus, carotid and aortic body. So this will be taking part in baroreflex and chemoreflex. It transmits the taste sensation from posterior one third of the tongue. Contraction of the stylopharyngeus muscles and takes part in swallowing, and parasympathetic fibers to parotid gland for salivation. Same repeated again. So you will do the taste sensation for posterior one third of the tongue. Carotid body, carotid sinus, aortic body and aortic sinus, we usually don't do any specific taste for baroreceptor as well as chemoreceptor. Part of the sensation to the pharynx and larynx part is along with vagus nerve. So this is a mixed supply, and vagus nerve will be supplying motor fibers to pharyngeal muscle, laryngeal muscle and palate. And this we do together the test what we call as gag reflex. So while testing for the 9th and 10th together, we ask the person to open the oral cavity and say, ah, breathe. You will see the palate elevation, soft palate will be elevated. While testing for the 10th, we look for the voice character, cough reflex, and together we look for the gag reflex. So glossopharyngeal is for the movement of the pharynx, swallowing reflex, and it takes part in gag reflex, while vagus nerve is mainly concerned with vocal cord, which will be for sound production. So together, tested together, you ask the person to pronounce R. You can see the movement of uvula, and you can also see the uplift of the soft palate. Phonation sound will be done by vocal cord, and that is by vagus nerve. In gag reflex, you will have both, that is sensory will be 9th, motor will be 10th, and swallowing reflex both will be taking part. So by and large we test together. Now if we want to test for the glossopharyngeal, we have to test for the posterior 1/3 of the tongue, in which, as we have discussed in 5th cranial nerve as well as 7th cranial nerve, you will have to ask the person, you will have to explain the entire procedure, you will have to rinse the oral cavity, ask the person to protrude the tongue, hold the tongue with gauze or cotton, don't use forceps. Touch the posterior 1/3 of the tongue with the solution containing a bitter solution or a sour solution, and person is not supposed to speak, and person is supposed to identify the taste sensation either by identifying the paper on which the name is written, and then you can repeat the taste on opposite side. This will be the taste sensation for glossopharyngeal nerve, and that you have to taste in the posterior 1/3 of the tongue. And you will ask the person to swallow a gulp of water, where you will be tasting 9th and 10th cranial nerve together. And when you ask the person to open the mouth and say ah, you have to observe the position of uvula, median raphe, and the arches of soft palate. Now this will be the uvula, this will be the arch. So both arches will be equal and nicely curved, and you will be able to see the uplift of the uvula. If there is an involvement of the glossopharyngeal nerve, you will have one arch being flat and uvula will be pulled to the opposite side. So whenever a person says ah, the uvula should remain in the center, both arch should be equal. You can see here this side arch is flat and uvula is pulled towards this side. So there is a paralysis of this, what we call as the right side. Here you can see both arch are equal and uvula is in the center. While here you can see this arch is flat and uvula is pulled to the opposite side. Here uvula is in the center, both arch are equal. So this is normal. Uvula will swing towards unopposed muscle action on one side. Here there is unopposed action. So it will be pulled towards the unopposed action. So this side is paralyzed. Now this is left side, this is right side of the person. So you have to open the oral cavity and say, here you can see both arch are equal and uvula is in the center. Here you can see that this is pulled up, uvula is towards the left side. So there is a right side palsy. So you ask the person to open the mouth, look at the palate, and then person will either cough or person will pronounce R, and you see the position of uvula and arches, asymmetrical rise of velum. And you can also do what we call as a gag reflex, in which there are two components. If you touch the soft palate, we call palatal reflex, and if you touch the pharyngeal wall, you call it pharyngeal reflex. So when you touch the soft palate, the sensory pathway is glossopharyngeal, and contraction of the pharyngeal wall as well as the uplift of the soft palate. This will be a motor component by vagus nerve, and person will have a gagging. You have to tickle back the pharynx with the swab stick. So sensory pathway is 9th, motor pathway is 10th. So this is a combined for 9th and 10th. We call gag reflex. When you touch the soft palate, we call palatal reflex. And with the cotton swab, if you touch the posterior pharyngeal wall, we call pharyngeal reflex. Together, we give a common name. We call as a gag reflex. So ask the person to say ah, and this is when you touch, you are doing a gag reflex. And also simultaneously, you are doing touch sensation. And this will be glossopharyngeal now examination. So as far as the motor function is concerned, you ask the person to speak. If the person soft palate is not moving properly, he will have a typical nasal twang. That is, when you ask the person to pronounce some word, it will be how are you? So that will be a nasal twang. And person will also have, while swallowing, there will be nasal regurgitation. This will be the two characteristic finding which you will get in a involvement of a glossopharyngeal nerve. And while opening the oral cavity, you look at the position of the arches of soft palate, position of uvula, median raphe, and you look at the movement of the palate and also the movement of pharyngeal wall. In case of ipsilateral palsy, say here, we have already shown you the diagram here. The left side of the arch is not moving, it is flat, and uvula is pulled towards right side. So there is a left side pharyngeal palsy. So absence of movement, flat arch, uvula pulled to the opposite side, nasal speech, nasal regurgitation suggest lower motor neuron palsy on that side where the arch is flat, and if uvula is pulled to the opposite side, or we call normal side. You can taste for posterior 1/3 of the tongue, sensation over oral cavity, tonsillar fossa, pharynx and palate. But by and large, we taste for the taste sensation on the posterior 1/3 of the tongue, and sensation you can taste in the oral cavity. Indirectly, we are doing in case of a gag reflex. So together, in a gag reflex, sensory pathway is 9th, motor pathway is 10th, center is medulla. So you touch either the palate or the soft palate and look for the gagging or contraction of the pharyngeal muscle you can look for. Glossopharyngeal nerve damage can produce one, glossopharyngeal neuralgia, very odd condition where person will complain of severe electrifying pain or excruciating pain in glossopharyngeal region. If there is a complete damage to glossopharyngeal nerve, the taste sensation to posterior 1/3 of the tongue will be lost. And person will also find trouble in swallowing. And when he tries to swallow, he will have a nasal regurgitation. And his speech will be typical nasal speech with nasal twang. How are you? What you are doing? This will be the typical nasal speech or nasal twang. And there will be decreased sensation, not taste sensation, but decreased sensation on the back of the tongue, in the soft palate region, as well as in pharynx. And because there is an effect on a soft palate, when you elicit the palatal reflex, the gag reflex may be diminished or may be absent because sensory pathway is damaged. And when you look at the uvula will be deviated to the opposite side because unopposed action of the damaged muscle. Because if right side is damaged, that is unopposed action of the left side muscle will pull the uvula to that side. That will be the peculiar action of the glossopharyngeal. So this will be the combined loss of taste sensation, loss of general sensation from posterior one third of the tongue. Sensation lost will be from pharynx as well as posterior one third of the tongue. Hence, gag reflex will be diminished or absent. While swallowing, person will find difficulty in swallowing and there will be nasal regurgitation. And in a speech, there will be a nasal twang. And if you taste for the salivation, you will have a decreased salivation from parotid gland. So, taste sensation from posterior one third of the tongue, difficulty in swallowing, loss of salivation, and unilateral loss of gag reflex. This will be peculiar in case of glossopharyngeal nerve palsy. So, in interpretation, unilateral lower motor neuron palsy, there will be damage in the upper part of medulla, either by vertebrobasilar artery like thrombosis, embolism or hemorrhage, or little not very common, maybe by poliomyelitis or by Guillain-Barré. In Guillain-Barré, it will be bilateral damage. In poliomyelitis, it is usually asymmetrical. Bilateral lower motor neuron palsy will be much more common in Guillain-Barré, bulbar poliomyelitis, and in case of motor neuron disease. So in these three conditions, you can have a bilateral lower motor neuron palsy. But very, very occasionally, you can have a unilateral because of the damage in the medulla, which may be because of thrombosis, embolism or hemorrhage involving vertebrobasilar artery territory. And among the taste sensation, we already mentioned sour and bitter taste sensation will be lost if there is a damage to posterior one third of the tongue. As far as the glossopharyngeal neuralgia is concerned, it is also called as a tic X of ninth cranial nerve, or it is also cranial mononeuropathy of ninth. And person will have a severe pain in the tongue region, throat, ear and tonsillar region, which will be lasting for few seconds to few minutes. And it is because of irritation of the ninth cranial nerve. It is sudden intensifying pain of burning nature, stabbing nature or excruciating pain, or it is also described as electrifying pain. There will be paroxysm of pain which will be initiated by swallowing or protrusion of the tongue or while talking or while touching the palatine tonsillar area. Pain will be in paroxysm and will be during eating, swallowing, etc. It is a very rare syndrome. The exact etiology is not known, but rarely by CP angle tumor or maybe because of a nerve compression also. Diagnosis is by a good history, and you can stimulate by touching the tonsillar area and pain may be triggered. And when you apply the lidocaine, the pain may be reduced, or you will not be able to elicit that pain again by stimulus that suggests glossopharyngeal neuralgia. The treatment is mainly like trigeminal neuralgia, carbamazepine, or you can use phenytoin, baclofen, amitriptyline, etc. as we use in a trigeminal neuralgia. And when pain is very severe enough, you can use the other drugs also. Very rarely, you might require avulsion. Clinical implications, you can go for baclofen, dilantin, gabapentin, tegaretol, etc. for glossopharyngeal neuralgia. So this was little introductory part and examination of glossopharyngeal nerve. It will be helpful to you. Again in repetition, you will have to taste for posterior one third of the tongue, taste sensation as well as sensory taste in tonsillar area, posterior one third of the tongue and palate. When you ask the person to open the oral cavity, look for the movement of the uvula, movement of the arches, movement of median raphe and movement of soft palate. In case of glossopharyngeal muscle paralysis, glossopharyngeal nerve involvement, the arch will not move, arch will be flat and uvula will be pulled to the opposite side because of unopposed action of stylopharyngeus muscle. And when the person is asked to open the oral cavity and pronounce ah, you will be able to identify much better. And you can also look for gag reflex, which is a combination of 9th and 10th cranial nerve. 9th cranial nerve is a sensory pathway and 10th cranial nerve is a motor pathway. Center is medulla. So if there is an involvement of the glossopharyngeal nerve on one side, you will have an absence of gag reflex or you will have a diminished gag reflex. And in case of a bilateral, the soft palate movement will be diminished or may be absent. Person will have a nasal regurgitation, nasal speech, and person will also have difficulty in swallowing, and that will produce nasal regurgitation. Thank you all for taking out time. I know that your time is valuable and I appreciate that you have spent some of the time with me. See you in next lecture. If you like this particular lecture, please don't forget to press button like, subscribe, press bell icon so you can get a alert message whenever I upload a second video. And if you feel it is helpful to your friend, you can share with your friends. So see you in next lecture.